Good evening, everyone. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare to this insightful panel discussion on glaucoma awareness, preventing vision loss through early detection and treatment. Glaucoma is often called the silent thief of sight, as it can progress unnoticed until significant vision loss has occurred. However, with timely diagnosis, regular screening, and the right treatment approach, we can help prevent blindness and improve patient outcomes. To shed light on this crucial issue, we have esteemed panel of experts who will share their insights on early detection, treatment advancements, and the importance of awareness in combating glaucoma. So, without any delay, I would like to introduce our distinguished speakers. Dr. Sneha Kankaria, glaucoma and cataract consultant at Dr. Agarwal's Eye Hospital, Mumbai. Welcome to our show, ma'am.
Thank you. Thanks a lot.
Thank you so much. Dr. Dinshaw Dastoor, consultant ophthalmologist at Holy Family Hospital, Bandra, Mumbai. Welcome to our show, sir.
Good evening. Thank you.
Thank you so much. We also have Dr. Rishi Bhardwaj, senior consultant ophthalmologist at Paras Health, Gurugram, but he will be joining us soon. So, without any delay, I would like to dive right into our discussion. First, by understanding what exactly is glaucoma. My first question is to Dr. Sneha. Dr. Sneha, glaucoma is often referred as the silent thief of the sight. So, could you help us understand why glaucoma is called that and how gradually it affects vision over time without, noticeable symptoms?
So, first of all, let's get into understanding what exactly is glaucoma. Okay. So, glaucoma is basically they're a group of disorders wherein these group of disorders are such that you have progressive damage to the optic nerve of the eye. Okay. So the most important risk factor being a raised eye pressure, which we call as the intraocular pressure. So most of us are aware about what the normal blood pressure should be. This awareness is there amongst the common man. They know that okay, their BP should be somewhere around 120/80. So similarly, there is something known as the eye pressure. So we would expect the eye pressure to be so whenever the eye pressure is above this level, in most cases, it can cause progressive damage to the nerve of the eye. And this is what can cause glaucoma. It's called the silent thief of sight is because there are no telltale signs in this, in the initial stages. You won't have pain, there won't be any redness, no blurring of vision in the initial stages. And that's why it's called the silent thief of sight. So when the nerve damage progresses, what happens is you will have an initial loss of peripheral vision. Okay, I do sometimes have patients coming in the clinic and they'll be like, okay, doctor, we're not able to see objects coming from one particular side. Very few people are, able to appreciate this peripheral loss of vision because most of the times we use a central vision and peripheral not use that much. But over a period of time, as the disease progresses, the peripheral loss gets more advanced and then it comes to the central field. And that's when we have patients. So by the time I have patients coming into the clinic that do say we have loss of vision, I would say almost the patient may be in the moderate or severe stage of glaucoma. And since it has no signs and symptoms in the initial stage, it's called the silent thief of sight.
Thank you so much, Dr. Sneha, for explaining us what exactly is glaucoma and why this is called silent thief of sight. Because there's not much of awareness around this. So, moving forward with our discussion, my next question is to Dr. Dastoor. So, there are different types of glaucoma, such as open angle closure, and normal tension glaucoma. So, could you elaborate on the key types of glaucoma and how they differ from different symptoms, progression, and the management?
Uh, it's a very, I would say, vast array of answers here to one single question that you're putting across. But uh, primarily, as in clinical practice, we would divide glaucoma as primary and secondary. When we say primary glaucoma, meaning glaucomas for which there is no known cause or no known secondary cause in the eye or in the body systemically, uh, where the glaucoma is in itself presenting for the first time in one or both the eyes, asymmetrically or symmetrically. Secondary glaucomas are those wherein there is some pathology, something going wrong in the eye besides glaucoma, which is causing the problem. That is a secondary type of glaucoma. Uh, Also, glaucomas can be classified into congenital or developmental glaucomas, wherein the child is born with glaucoma in utero or just after birth, infantile glaucoma, juvenile glaucoma, and the other second variety, that is the acquired glaucomas. Uh, as you also mentioned, open angle and closed angle. Now, when we say open angle and closed angle, what is this angle business? The In a very simple layman's term, I'm sorry, to describe the angle of the anterior chamber, it is basically a very intricate structure in the eye, which is responsible for the drainage of the clear aqueous fluid, which is constantly being formed in the eye throughout one's lifetime and is being drained gradually out of the eye, a constant cycle which is taking place. There is a variation in the pressure, a normal variation, what is known as diurnal variation, which usually extends to about 4 to 5 millimeters through the day, usually lesser in the morning, higher in the afternoons, and so on. Now, the angle of the anterior chamber of the eye, that is the front portion of the eye, which is, I would say, covered by the transparent dome of the eye, just like compared to the glass of your watch, the cornea, and the
Yeah.
posterior portion of the colored part of the eye, that is the iris. The part where the iris joins the cornea, that part is known as the anterior chamber angle or the angle of the anterior chamber. That's a very, very intricate part of the eye through which the aqueous fluid is being drained. Open angle glaucoma is where the angle is open and still there is a rise in intraocular pressure. Angle closure glaucoma or closed angle glaucoma is where the angle is closed, and because of that angle closure, for whatever reason, there is a rise in intraocular pressure. Way of
Thank you.
describing open angle and closed angle.
Yeah.
It gets a little more complicated when I say neonatal or juvenile or developmental glaucomas or infantile glaucomas, where the child, or congenital glaucomas, where the child is born, a newborn child with glaucoma. It's a very, very complex state of affairs, extremely difficult to diagnose initially, extremely difficult to treat also. And then the other part, which is the developmental glaucomas, which we come here with open and closed angle. The more easier way to understand it is the primary and the secondary glaucomas. The primary, where there is no known cause in the eye or the body which is causing glaucoma, rise in intraocular pressure or variation in intraocular pressure, and secondary glaucomas where there is a pathology in the eye or in the body systemically. For example, hypertension, diabetes, so on and so forth, causing a variation or a fluctuation which is out of its excess. Now, when I say out of its excess, a fluctuation, a diurnal variation of more than 5 to 6 millimeters through the day will, over a period of time, cause irreparable damage to the optic nerve of one or both of the eyes. So, in short, this is a broad array of description of the types of glaucomas one would encounter in clinical practice.
Thank you, sir, for explaining us to that. Like you said in the beginning, it's a wide array of topics which I asked at collectively, but still you answered it very well. Thank you so much for that. Moving on to my next question, Dr. Rishi. Welcome to our show, sir.
Pleasure, ma'am. Thank you so much.
Thank you, sir. So my question to you is that certain individuals are more prone to developing glaucoma. So could you share your insights on who's at more risk of it, whether due to a genetic age or some lifestyle factors, and how these factors contribute to the development of glaucoma?
Okay, so more prone to glaucoma is again dividing into subsets, which Dr. Dastoor already said. There are different factors for open angle glaucoma, there are different factors for closure glaucoma. So when we keep it widely, minds who are high minus powers, they are sometimes more prone to develop open angle glaucoma. Hyperweight, that means plus power for distance, not for near, they are more prone to close angle glaucomas. People in the equatorial belt, the African region belt is very prone to open angle glaucomas, primary glaucomas. Congenital glaucomas also. Unfortunately, the incidence is lesser in our country compared to the African region. So there are certain genetic factors which affect these conditions. Diabetics are kind of more prone to glaucoma, but symptoms of diabetes can appear later in glaucoma prone people. Diabetic glaucoma is also prevented to diabetic retinopathy to some extent. So there is a mixture of interplay between diabetes and glaucoma. So many such factors, very small factors like your fluid intake. Some studies claim that how tight or how loose you wear your collar button or your ties, even such small factors can play a role in glaucoma.
Thank you so much, Dr. Rishi, for that answer. Uh, my next question is to Dr. Sneha. Ma'am, since glaucoma damage is irreversible, so can glaucoma be prevented in any way, or is early detection the only situation to reduce the risk of the permanent vision loss?
So basically, when we talk about glaucoma, I do uh, quite a few people think that glaucoma equals to blindness, but I'd like to say it's not that way. Okay, the first step to preventing anything, what's very important is we must be aware of this condition. So what I'm seeing in my years of practice now that I'm seeing is that now because of a lot of digital platforms being available and a lot of information is available, so people are becoming aware, especially patients who've had any, who've been diagnosed elsewhere to be a suspect for glaucoma or who have a family history. They're at least coming in for these routine checkups and regular checkups. I think awareness has a very important role to play in prevention. Number two is those who've been diagnosed with glaucoma. Yes, we can prevent vision loss. What we need to understand is we can prevent the progression of the disease by timely interventions because we've got various treatment modalities that are available. So it doesn't mean that, okay, you've been diagnosed with glaucoma, you're going to be blind. No. In most of the patients, especially the ones in the early stages and moderate stages, we can arrest the development by getting the most important thing is keeping the eye pressure under control. And if the patient has some certain systemic diseases that play a role in glaucoma, we can keep that under check. We can prevent, further vision loss. So I think detecting early is very important, is because then we can intervene early. There are certain subsets of patients who don't have glaucoma, but just their eye pressure is on the higher side. Like um, Dr. Dastoor sir has already mentioned that, ocular hypertensive patients we do have. The pressure is high, we can prevent them from actually developing glaucoma. So, yes, vision loss can be prevented with timely intervention and early detection.
Rightly mentioned, ma'am, timely detection and the diagnosis helps it makes our way much easier rather than going forward for the treatment and every other thing. If we have it is being diagnosed on time, we can have treatment less complicated, which takes
Yeah.
lesser time, or we can avoid the all the complications. So now focusing more on the importance of regular eye examination, my question to Dr. Rishi is, so given that early detection is the key, how often is the key to prevent glaucoma or any other eye disease we call it? So how often should individual from different risk categories go for this glaucoma screening? Risk factors could be, like high risk family history or elderly or any other lifestyle factors.
So, we have a lacking trend of regular eye checkups. We tend to come for a regular eye checkup, actually for an eye checkup when we have a problem. Or, we get scared because some neighbor or some family member or somebody had gone through a problem. So, I think yearly thorough eye checkup, which should include dilatation or posterior segment evaluation to an extent. That prevents a lot of problems, and glaucoma is, of course, one of them. So, as far as risk factors go, family history, we should start early detection and early screening if there is a strong family history. Especially maternal side family history is considered to be stronger. If you are a high mild, that is a high minus power or a high plus power, if you have certain symptoms like people or things bumping into you, not realizing that who came from there, but that still comes when there is a legitimate field defect that have come in. Like both the doctors have explained that it causes field construction. So that symptoms come at a later age. Not waiting for the symptom is the best part for screening. 40 and beyond 40 annual screening should almost be considered mandatory. At least in metros, this is becoming a trend and people are becoming more aware, more careful. But yes, rest of the places we still need to work more for awareness and just for regular checkups. There need not be a symptom, there need not be a risk factor because this is like Dr. Kankaria explained a silent thief of life. So outside. So why wait for a symptom to get a screening done? And 1 year is a large enough period. Steroid use causes a lot of propensity to glaucoma. And nowadays we see a lot of medicines, a lot of herbal medicines, a lot of contemporary medicines, gym products. They use a lot of steroids which are not labeled. So all of these are pro factors for glaucoma. So I don't suggest waiting for a symptom. But yes, risk factors should lead to early screening, and 40 and beyond should lead to annual screening minimum.
Thank you, Dr. Rishi, for shedding light on importance of how regular we should go for eye checkups and screening, why we should not wait. Because normally the awareness around eye health is not so common. People does not know how to take care of their eyes and how much to wash, what all eye drops they can add, whatever is given by the chemist and everyone they use it, irrespective of whether knowing it is it good for their health or not. So I think that basic knowledge, that awareness, education is still lacking, and we need to focus more on that. But moving on to my next question to Dr. Dastoor. So, what are some of the most effective diagnostic tools which is available today for the early glaucoma detection, such as OCT, tonometry, or any visual field test? So, could you briefly explain their roles?
Yeah. Normally in the clinic, any good setup that we have all over, apart from simple checking of the grade of vision, that is visual acuity, with or without glasses, which is a very, very simple but important test, which we very often take for granted. We very often say, we skip that. We say we don't bother. We leave it to the optometrist and say, okay, fine, let the optometrist do the job. Visual screening, meaning visual. What is the grade of vision? 6 by 6 vision, that is normal vision, with or without glasses. That is important. That gives us a hint that possibly if it is not normal, there could be something wrong. Now, what could go wrong? There are 101 things that can go wrong. As far as we are concerned here with today's topic of glaucoma, the tests that are easily available and can be easily done most important, of course, is to measure intraocular pressure. That is known as tonometry. There are different types of instruments for tonometry, right from the old Sears tonometer, which is practically outdated today, but still very works very well, if you ask me. In cases where it's not possible to have high-tech setups, the normal applanation, which is the gold standard, I would say, even today, and I go by that because I use it on a regular basis. You can't compare the applanation readings with any tonometer. Believe me, in my many years of practice, I have seen its accuracy is fantastic. It is very dependable. Of course, yes, you need a little bit of cooperation from the patient, but if you explain to the patient what you're going to do by doing an applanation, it's a technique wherein you are anesthetizing the cornea of the patient so that the patient is pain free. Ask the patient to keep both eyes open, not to squeeze too tight, and then the instrument is touched upon the cornea. There are certain laws by which one is very important, the Imbert Fick law, by which we measure the pressure of the eye, intraocular pressure. It's a very, very accurate measure of way of measuring intraocular pressure. On a broader scale, in camps, for example, or glaucoma screening camps, you don't have the time to do applanation. We may use non-contact methods, air puff tonometers, non-contact tonometers, which are equally good, which give us a good idea or reading of the intraocular pressure. But usually non-contact, I've also used, I have it in the clinics, and they normally they are on the higher side, 3, 4 points higher than normal. So we have to take it with that in mind. Apart from measuring intraocular pressure, tonometry, uh, very, very important test nowadays available, OCT, the ocular coherence tomography, which gives us a very, very accurate picture, a color coded, so called two-dimensional cross section of the retina, especially the retinal nerve fiber layer, as well as the optic nerve head. That is the part which we are dealing with as far as damage, permanent damage because of due to glaucoma, and especially when you are trying to uh, progression of glaucoma in a particular patient, we can take follow up and pictures of the nerve fiber layer, thickness of the nerve fiber layer, the progressive damage to the optic nerve head, what is known as the optic disc. uh, the optic disc itself, apart from OCT, yes, OCT is a very, very accurate measure, a photograph, a picture, but I would still depend on my fundoscope, fundoscopy, simple fundoscopy. It may be direct fundoscopy, it may be indirect fundoscopy, whatever. But fundoscopy itself, that means you are actually visualizing the optic nerve head. You're seeing the optic nerve head, you're seeing the retina, you're seeing the status of the retina in each eye. Pupil may or may not be dilated because, as we know, that in glaucoma patients, there is a risk of angle closure if you dilate the pupil. So it's a catch-22 situation. Very often, my optometrist will come and say, "Doctor, this patient has a history of glaucoma, and should we dilate?" I mean, it's a question which I would again there's a debate there because very often elderly patients have cataracts. Now, when you have a cataract, you're talking of an opacity in the eye, which is limiting your vision of the retina at the back. Even with a dense cataract, you will not get a good OCT picture after even dilating. So it's a very funny situation here. But what I'm trying to say is, if you can see the optic nerve head with experience, believe me, just that one single second of visualizing the optic nerve head, you can head on and directly say, this is a glaucoma patient or a glaucoma suspect, or this is a patient who is mimicking glaucoma. This optic nerve head mimics glaucoma. Very many times we mistake glaucoma for something else, or something else is mistaken for glaucoma. So it's a wrong diagnosis, and then the patient is treated on the lines of glaucoma when there is no glaucoma in the first place. So that is fundoscopy. Although it may not be as a gold standard of glaucoma testing, but I still believe that it is. Third, very important apart from OCT is visual field testing, that is perimetry. And there are many programs in perimetry, different types of parameters available, but it's a little bit more elaborate because it needs time. The patient has to cooperate, the patient has to understand what is to be done. And what do we mean by perimetry? It's basically testing individually, each eye at a time, the visual field. Because the visual field is what suffers, what takes a toll when glaucoma progresses. It's a narrowing of the peripheral visual field gradually, ultimately where the central visual field, where ultimately you get tubular vision and patient ultimately lands up with blindness, total blindness. So it's your peripheral visual field which goes first, and then gradually those it constricts. Now this perimetry, this what is known as automated static perimetry, these are tools which are again where you can follow up and do on a regular monthly, 3 monthly, 6 monthly, or even annual basis, which will tell us whether there is progressive damage to the optic nerve head, whether the glaucoma is stable, or sometimes even I've seen glaucoma reverse to some extent. I'm not saying reverse where nerve is already damaged. Nerve cells cannot regenerate. We know that. But if we at least bring the pressures down to achievable target pressures, we would anticipate a positive result, a better perimetry result. And there are many programs in perimetry. I don't want to go into detail because that takes too much time. But these are our basic tests. One more test, yes, of course, evaluation of the angle of the anterior chamber, which is done by gonioscopy, gonio lenses. That is done on a slit lamp, which you can see behind Dr. Sneha. That instrument is invaluable for all ophthalmic surgeons. The gonio lenses are of different types, and there are very many ways of doing gonioscopy, and that evaluates the structure of the angle. You can actually see the angle. Naked eye, it's not possible to see the angle because of total internal reflection. It's a physical principle, optical principle. So we need gonion lenses to evaluate the structure, the angle in all 360 degrees, whether it is open, whether it is closed, whether there's some pathology in the angle, it gives us a better picture. So these are basically my four techniques on which you can depend and say, okay, this patient has or is suspect of glaucoma, or definitely has glaucoma and needs urgent attention.
So you have explained us the diagnostic techniques and tools in a very simple layman language that everyone out there who's listening to this would understand basically the diagnosis process, how it is diagnosed based on the each complication and how helpful it is. Because to understand the disease is one, but to understand its diagnosis and treatment, to have the trust in that, how it will benefit, how it will work, and all is something different. Is something else which which gives you that faith. Okay, these are the things. This is how it will work, and things will be so. It will be good after that. So thank you so much for elaborating on that. Moving on to my next question, Dr. Sneha. Ma'am, many people tend to skip the routine eye checkups, which often leads to late stage glaucoma detection. I think that's the habit of every individual, or I should say, in our country, that we fear from the diagnosis, right? So, how can we encourage the general public to prioritize the regular eye screening for early detection?
So I think it's not just our country, yeah. Everywhere this is the problem. Like even if I am told I don't have any signs and symptoms, I'm not going to go and get myself a scan or a something. This is reality. So like we said, the first thing we need to address is that somewhere when we do not have signs and symptoms, we as patients will not do examination. So one is the reason that because we don't have signs and symptoms. Number two, I think, which is very important though, is I do come across patients like these in my clinic where I have diagnosed that okay, they have glaucoma, they need to do certain basic tests. See, picture. Okay, in the advanced moderate stages, okay, yeah, this is glaucoma, but there are certain gray areas. One test can't help us with glaucoma. So there are a couple of tests like Dr. Dastoor described. So they come at a cost, okay? So So I think cost is also a barrier for our patients to do these tests. Maybe all of them aren't affording. So when they don't have signs and symptoms, and though I have diagnosed them, they might not do these scans. So I always make it a point to explain to my patients why it's important. There are various I would say facilities that are available where these scans can be done at a lesser cost, affordable cost to our patients. But cost plays a very important role in our population, though, where we don't do a routine checkup also. So I always tell my patients nowadays that at least in our cities, that you all have the eye care has advanced so much that I would say almost in 1 kilometer you will have an ophthalmologist or 4 5 ophthalmologists at least, right? So take advantage of that. Okay, so get an eye examination done because you have access. Now see, when we go and we sort of meet other people outside our country and all, what we see is patients don't have access to doctors. So the way I pitch to my patients is like, you'll have access to doctors. So I mean, that's the best thing that for healthcare. So when you have access, please get an eye examination done. And also, if you have family history, we have to keep emphasizing to our glaucoma patients as well that please get your family members checked, because the inheritance rate is almost 40%. So just a little bit of awareness, more chair time, emphasizing why it's important. I think eventually most of them do come in for a detailed eye checkup. But still, we have a long way to go, because I think the first thing that patients do is that they go to an optical store and they get, their eyes checked, they get the glasses par, and they're happy because they're reading everything. But again, people with moderate glaucoma and advanced glaucoma can read what is shown in the optical store, is because the central vision is still preserved. Okay, peripheral vision is lost. This is not picked up at a store. So that is why anybody above 40 should get their eye checked once a year. That's the least that one can do for their eyes, because, like I'll always say, when we are aware, we are intervening early, it really makes a lot of difference. Yeah.
It does make a lot of difference when we intervene early, and like you said, regular checkups and all. You mentioned a correct point, Dr. Sneha, that we do not go to doctor until unless we have any symptom or signs or anything like that. And it's not just in our country, it's, I believe, everywhere. It's the general mindset we have. But despite that, we know how much of advancements in everything we have come up. We still ignore, even if we have few signs and symptoms. And like you said, we just go to the general store and then pick up a glass. And we are fine with the daily routine. Uh, so that was about how a general public perceive. But talking about so Dr. Rishi, talking about the accessibility. So accessibility to glaucoma screening, especially in rural areas or underserved areas, remains a major challenge. So what steps can be taken to improve access to early detection and ensure timely diagnosis in such regions?
See, I think there are two parts of this accessibility. One is availability of a ophthalmologist in that given area. Uh, in my experience, it's not very good. Okay. The number of ophthalmologists might be lesser when you go as you go away from the metros. But I have not seen a two-tier or three-tier or even a small town place where there is not at least a handful of ophthalmologists. Uh, Dr. Dastoor has explained such a wide array of diagnosis, a very simple shots, which is a old and still a very affordable medium to judge pressure, intraocular pressure, and something as simple as a slit lamp eye microscopy to see the optic nerve head. These two basic things can be done in almost every ophthalmologist clinic. So this should not be skipped. Sometimes patients do not understand the process entirely because it can become lengthy. You have to sometimes wait. You have to get your IOP checked at the last. Before that, you have to get your fundus checked. So it can include some time also. And one might think, oh, I have no problem, why do I have to give so much time? So that can be one of the issues. But barring that, at least these two basic checkups are available in almost every corner of our country. And we are very happy about. And places where all these towns are connected somehow to big institutes in a city. There are regular screening camps done, though the screening camps might not be diagnostically very robust, but at least they do provide a medium for general screening. And once the awareness is good enough, these can also lead a lot of awareness activities. Patients or general population can make use of these camps which are conducted in such a large scale by bigger institutes. A private practitioner can only do so much, but an institute can actually cater to such a large area in a big, robust way. That is still a very developing feature in our country. With we call it the hub and the spoke pattern. The center remaining in a metro, or now even institutes are developing in out of the metro region also. So we are very glad that such systems are being taken care of.
So I believe willingly, yes, it is a bit difficult that every person out there come for the screening. But if a campaign is being organized in such areas where they are being screened for the glaucoma or any other eye issue, I think that could cover larger mass, a larger group of people. But willingly, I think it's a bit difficult in our country, as we are in process of raising that awareness, motivating, encouraging them to focus more towards prevention rather than the treatment. But focusing now on the treatment and the advances in glaucoma management, Dr. Dastoor, when it comes to glaucoma treatment, what are the current standard treatment options such as eye drop, laser, or surgeries we have, and how effective are they in managing the condition?
Uh, Treatment wise, yes, okay. Now we've come to a diagnosis. Okay, this patient has glaucoma. We've measured the intraocular pressure. One eye, say 23, 24, the other eye 30. That itself is an alarm because there's a variation between the two eyes. Both eye pressures are on the high side. I have made my diagnosis and I have confirmed that yes, I need to treat this patient. What would I do first? Naturally explain to the patient that this is the problem, and would have to start the patient initially on topical or local eye drops, what are known as anti-glaucoma medication. The standard age-old drops that we still use today are what are called as beta blockers. These are drops basically which are very effective, have always been very effective, but they do have side effects also. Basically, the issue here we are talking about, I'll make it very brief, is that there are enzymes known as carbonic anhydrase, which are in the body. And these enzymes increase or decrease the production of the fluid, aqueous production in the eye. These drops are basically acting against the production of aqueous, or they decrease the production of aqueous. So if the production of aqueous or secretion of aqueous is reduced by these beta blockers, what are known as, the intraocular pressure automatically comes down over a period of time. Timolol is an age-old drug, but timolol has its side effect because it's a non-selective beta blocker. There are selective beta blockers, which are known as cardio-selective beta blockers, betaxolol being one of them. When I say cardio-selective or cardiopulmonary selective, because there are receptors also in the heart as well as in the lungs. If I give a timolol maleate drug to a patient who's an asthmatic, he may even succumb to asthma, and that is surprising, but it can happen and it has happened. So we have to be on guard as to which drug we are giving, even though it may be just an eye drop. The other gold standard nowadays we rely on as first line of treatment are what are called as prostaglandin analogs, latanoprost. One of the trade names being Zalatan. It's a super drug, wonderful drug. It reduces, not only reduces the production of aqueous, but also increases the so-called non-trabecular outflow of aqueous. the uveoscleral pathway. It's a very, very intricate method by which aqueous passes out of the eye. It increases the uveoscleral outflow of aqueous. And some of these drugs also increase the circulation to the optic nerve head, the vitality of the optic nerve head. We know the whole body, all our cells depend on blood, oxygen, nourishment. So these drops and these topical medications give vascularity, give more nourishment to the optic nerve head, because it is the optic nerve head and the optic nerve fibers which are taking the brunt of everything and ultimately dying out if it is not checked in time. Other drops are also available. There are many types. Myotics, for example, which decrease the pupil size. Where will we use a myotic? In a patient who we suspect and we know that he has angle closure glaucoma. If the pupils dilate in a patient of angle closure glaucoma, if you dilate, or if by some chance, say the patient, the individual goes into a dark room or he goes to a movie where it is dark, the normal reflex of the pupil is to dilate, to let in more light. The minute the pupil dilates and he has a narrow angle, he's gone for a 6 because he has angle closure. He'll have an episode of severe angle closure. He'll have terrible pain. He'll be in distress and he'll be completely, flabbergasted. What's going on? I can't see. So the drugs which act in the opposite way, where you minimize the size of the pupil, myotics, pilocarpine, 1%, 2%, 4%. I don't know if 4% is available anymore, but 2% is fairly easily available. Myotics are another form of drugs. Now, these are drops. Now, suppose now I tell a patient, okay, you have to be on drops for. He says, how long? I tell them it's like your blood pressure medication. You've got to be on drops lifelong. And they get a bit surprised because they expect that you will put it for a month and we can stop. That is another catch. It's a terminal problem with glaucoma management. Compliance of the patient for his treatment, which is in his favor, he forgets about it, or he says, "Oh, I forgot my drops at home. I went on a holiday. I had a super time in the UK, and I forgot my drops at home. I couldn't get them abroad because I didn't have a prescription. Blah blah, whatever." All said and done, patient compliance is extremely, extremely vital and very important for treatment and management and further progression of glaucoma to monitor it. If a patient is non-compliant, say for example, or the patient's pressures don't come down with medication, topical medication, then we have another uh, pretty good way of managing this, provided the angle is open again in the form of lasers. We have argon and diode lasers, which are used for what is known as laser trabeculoplasty, selective laser trabeculoplasty, because lasers are used to make tiny little burns in the angle, provided you can see the angle through gonio lenses. And by doing that, by making those burns, you are actually opening up the angle. So therefore, making you're facilitating the passage of aqueous, aiding the aqueous outflow from the eye, outside the eye. That is done with the help of lasers, laser trabeculoplasty. Laser trabeculoplasty has a success rate. Some of the books say 30%, some say 40%, some say all sorts of things. But personally, I don't have much experience as far as that is concerned because I don't do it myself. But it is one of the modalities of treatment available for patients who are either A, non compliant, or who don't respond to glaucoma medication topically. Third, in patients of, as I told you, closed angle, narrow angle, where I told you the man walks into a dark room, his pupils dilate, and he has an angle closure episode, which can be disaster. In such patients, we can also use lasers, and we do that by making a tiny opening in the iris, the colored part of the eye. In different segments, you may do one, two, or three or more openings, tiny little openings, to make a sort of a shortcut, a passageway, a bypass from the posterior chamber where the aqueous is being produced into the anterior chamber, so that angle closure episodes don't take place.
Yes.
This is known as a peripheral buttonhole iridectomy surgically. It's known as a laser iridotomy in the OPD. It's a straightforward OPD procedure done accurately. It does very well. If that doesn't work and still patient's pressure still remain high, patient shows progression, you know that it's not working, then we have to resort to conventional surgical techniques. The again the gold standard and age-old surgery, which we've all gone through and we all still keep doing, done well, it works beautifully. Trabeculectomy. It's a surgical technique which is done so that you are creating a passage for again aqueous to pass from the anterior chamber angle out of the eye, so that you're facilitating the drainage of aqueous out of the eye constantly. Now there are drawbacks to this also. If done, you are you're creating a kind of a bypass or a passageway for fluid, aqueous fluid to go out of the eye. At the same time, the body heals by fibrosis. So when you are one side creating an opening, the body will try to repair it by healing. So that opening might reseal itself. And that's where your surgery after 6 months or a year might fail. And you'll say, oh, it worked for 6 months, 9 months. And then, then again, the same problem has arisen. Why? Because the passage which you made has again closed, so to speak. It has fibrosed and sealed itself. There are drugs which can be used for such surgeries when you repeat it again by what are known as anti-metabolites, mitomycin C, 5-fluorouracil. These are wonderful drugs, but you have to be used with caution during the surgery if you have to repeat a trabeculectomy, which prevent this from recurring. End stage surgeries after trabeculectomy, if surgeries don't work in very complicated glaucomas, congenital glaucomas, which are extremely difficult to treat, we may use implants, shunts, which are devices where the tube is passed and into the anterior chamber, and an explant is placed so that fluid directly passes out. And in the end stage cases where the patient has practically lost all sight, it's a painful blind eye. Now we have a problem here because the patient is in distress. He has extreme pain because the pressures are 50, 60 millimeters of mercury plus, not responding to anything at all. We then have to resort to a procedure what is known as cyclodestructive surgery, wherein we are actually destroying the ciliary body, the part of the eye which produces aqueous, by lasers or with cyclocryotherapy, so that ultimately the aqueous production stops permanently. This is done as a last resort to cure the patient, not cure, but to relieve the patient of the pain that he's undergoing. He's lost the eye, it's a blind eye, but he's in distress. It's a painful blind eye. So, to prevent the pain, to reduce the pain and give him comfort, we resort to this last type of surgery. These are your, in brief, modalities of treatment.
Thank you so much, Dr. Dastoor. That's a quite complex process which you explained us, and I believe there's so much which goes into this for the treatment, and even if we have a lots and lots of advancements to it. But my next question is to Dr. Sneha. Dr. Sneha, there has been a lot of buzz around laser therapies like selective laser trabeculoplasty as a preferred first-line treatment. So, how does this SLT compare to traditional medication and its gaining acceptance as a primary treatment?
Yeah, so I think Dr. Dastoor already mentioned about SLT. It's selective laser trabeculoplasty. So basically, let's understand what it is. It's a procedure where a laser beam is shot to one of the areas of the eye called the trabecular meshwork. There are certain pigmented cells in the trabecular meshwork where we aim the laser light, due to which there is a better eye pressure control. Okay, mainly because the trabecular meshwork um, is responsible for draining fluid out of the eye and maintaining the eye pressure. So this is how exactly this laser works. It's an OPD procedure. That means I don't have to take the patient into the operation theater. Takes about 15-20 minutes for both the eyes. And the post procedure care is not much. Okay, you just have to use a couple of drops, and the maximum side effects that I have seen in patients is they may have mild redness, a little bit of swelling. There could be a spike in eye pressure, which is again very temporary. It's transient, just 1 2 days. So, like I said, there's a lot of advancement in glaucoma care. And, to begin with, many years back, we just had 1 2 drops. Then we had our trabeculectomy, which is the gold standard surgery. Then we got in tubes. But somewhere, I think I do offer SLT as the primary line of treatment in patients who are just newly diagnosed to have a high eye pressure and they've not yet having any nerve damage. Those are ocular hypertensive patients. I offer it to patients who are non-compliant with medications and they're in their early stages. See, when we start medications to somebody who's in the early stage of glaucoma, he has no symptoms, okay? So basically, he's putting everyday drops where cost is also a factor because these drops are expensive. And he has no symptoms, so he's wondering, why am I putting these drops every day? And then the compliance gets affected in a couple of months. So when we do that, that every visit share time, I do always explain the patients the importance of drops. But when they're non-compliant, then the early stages, I do offer it. So it's a very safe procedure. It's effective if the patient is selected properly. Like how rightly Dr. Dastoor said, the angle has to be open. I can't do it in secondary advanced glaucomas or patients who've put drops for 5 10 years. My laser is not going to work. So if the patient selection is very right, it works. It's again repeatable, and like I said, there are no side effects. So it's gaining a lot of popularity. It is my first line of treatment offered to the right patient. And again, doing or advising a procedure, somewhere our patients think that, okay, I did the laser, my pressure will be under control for the rest of his or her life. This is not the situation. Okay, as you know, as doctors, by now we know that whenever we do any procedure, the patient thinks this is the full and final thing. So that's very important thing, is that counseling is important. Even after laser, you need regular checkups, which is monthly, 3 monthly, depending upon your eye pressure. Maybe the laser will work for a couple of years. It has good efficacy, but it is not going to work lifelong. So, in the future, you may need other treatment modalities. It may be more drops, it may be stent, it may be, any surgical intervention if required. But understanding that glaucoma is a chronic condition, pressure will not be under control for the rest of the life by one single treatment modality. And just intervening at the right time with different treatment modalities is what gets the pressure under control, and SLT surely has a role, um, if done in the right patient. Yeah, again, it's not going to give you lifelong pressure control, but yes, it pushes the number of years. The patients that we've done here, we've seen that the number of years they require drops, I can just prolong it, because these drops also have side effects. But now there are a lot of preservative free medications that we are seeing. But if compliance is an issue, then yes, SLT can be, offered to the patient. Yeah.
Very, very rightly explained, Dr. Sneha, and thank you so much for explaining us what exactly is this SLP and how it, it affects, it benefits, and all the process. Because I believe, like I said earlier, also we need to have basic understanding of the treatment options. Also, we have, so that we know at what direction we are moving forward. My next question is to Dr. Rishi. So, apart from medication and surgeries, do you think lifestyle modifications like healthy diet, exercise, stress management, and limiting screen time will positively impact glaucoma progression also?
I think progression is not very closely related to screen time, but there are many small factors which have been slowly studied. Okay, one of them is say we talk about fluid intake. Now there's a very simple test. We give a lot of fluid to a patient in layman and then see the change in the time pressure. So that's called water drinking test. Now this has two factors. Drink a lot of water at one given time, your pressure tends to increase. So we also explain patients how and when to drink water because drinking suboptimal amounts of water causes low perfusion pressure. Perfusion pressure is basically the pressure at which blood flows and nutrition exchanges at the tissue level. So, drinking appropriate amounts of water very slowly in bits and bits and not, gulping down half a bottle together. So, such small things. There are small studies which have compared the time, tightening, may or may not be very related. Exercise is not directly related with glaucoma and its incidence and prevention, but exercise does have a role in increasing the blood flow and the vascularity. So, like Dr. Dastoor already explained, the main factor is blood and reaching to the optic that saves the nerve. So definitely, maybe exercise has a role towards that. So considering holistically, sometimes holistically to an extent where we need to involve counseling for the patient because the patient comes in so scared and so withdrawn with the diagnosis of glaucoma because though in good intention, but some of us do tend to scare the patient a lot that you might go blind, you might go blind, and you have to get this treatment. It is all done in good intention, but sometimes the patient withdraws from the diagnosis and from the treatment both. So even to the extent of that, we have taken psychology help and counseling help for such patients. Then we also tend to judge patient is non-compliant to what, whether he is non-compliant to the treatment or whether he is non-compliant to follow. Because non-compliance to treatment still has options, but non-compliance to follow-up in glaucoma does not have options. Because like Dr. Kankaria said, it's not one treatment that's going to make it go away forever. So you have to keep showing. So we explain, okay, non-compliance for treatment, I might, for a very non-compliant patient, go ahead with the surgery. Non-compliance for follow-up is going to be very dangerous. So except the treatment, there are many basic patient factors, including what he feels, how much he is educated, and what all he's doing through the day. Nutrition has a effective role. Minerals and electrolytes have an effective role in perfusion and nerve protection. So all of these have to be taken care of as far as the holistic management process goes.
Thank you, Dr. Rishi, for explaining us what all factors does it affect. As we are moving close to end of a session, my last question would be to Dr. Dastoor. So finally, if you could leave our audience with one key message about glaucoma, what would it be, especially in terms of prevention, early detection, or lifestyle care? As now we are focusing more towards the prevention rather than getting it treated on time. If we get it, diagnosed early, we would not require treatment, I believe.
Uh, like both my fellow panelists, Dr. Sneha and Dr. Rishi, have said that regular eye checkups cannot be ignored. That's all. The bottom line is if you're over the age of 40, apart from needing reading glasses, as we all have, as they say, you know, you're growing old now, you're over 40, so you need reading glasses. Well, the same way as you would go for an eye checkup for reading glasses, not necessarily to the optometrist, but to your eye surgeon, a regular annual checkup, I would say, is a must. If we don't look after ourselves, uh, nobody is going to. You have to help yourself at the end of the day. It's a very simple uh, fact. So, apart from our body, the eyes, which are, I would say, yes, I'm biased because I'm an eye surgeon. It's one of the most vital senses, most vital organs in the human body. and we can't ignore it. We can't take it for granted. We do take it for granted. That's the whole thing. We cannot take the eyes for granted. So look after your eyes. Simple things like, first of all, keeping your eyes clean. It's just like having a bath or washing your face. At the end of the day, you need to look after yourself, look after your eyes. And that does not mean that, okay, I'll go to the eye doctor when I have a problem. You go to your eye doctor on an annual basis, not just to get a number check or increase in your refractive index or power of glasses, having a new frame or something fashionable because your neighbor has it or whatever, but you need regular checkups. And in those regular checkups, you never know. Something might just come up. And the issue to understand is awareness. Patients today are primarily, when you talk about eyes, they say, chashma or motia, cataract. They have very little knowledge about glaucoma. They say, what does that mean? They can barely understand the word. What is glaucoma? And then, when you explain to them, they get their backs up and they say, oh my God, I didn't know that. So there is a lot of uh, there are a lot of misconceptions, and there's a lot of not much awareness, a general awareness to the public about what this condition is all about and how debilitating it can be. Because, as the first question was, the silent thief, the answer, why is it called the silent thief of the eyesight? Because it creeps up on you silently and you won't know it till the very end. And by that time, the nerve damage is so severe that you cannot rectify it, and it's gone. Your eyes are lost. So awareness is most important, and therefore I would say not only regular checkups, but I think as uh, most of us try to, in whatever way, media, as we are doing right now, in the newspapers, in magazines, send out flyers. Every hospital, every nursing home, put up more awareness, put up posters about glaucoma. Why about cataract all the time? I mean, yes, it's our bread and butter. Most anterior segment surgeons, we love it because that's what it is. But glaucoma is also important, it's very vital. And unless if it goes unchecked, then you're asking for big time trouble. So at the end of the day, I would say look after yourselves, look after your eyes, and you should be good. That's it.
Thank you so much, sir, for giving us that closing message, a very powerful closing message. Because yes, we take our eyes for granted. We see this beautiful world with these eyes, but we do not take care of them. And thank you so much for stressing upon the prevention and explaining us all the treatment processes, the diagnostics techniques we have. And thank you to all the panelists for coming and sharing their valuable insights and educating our audiences about this important issue on Glaucoma Awareness Day. So it means a lot, as this is an collective effort to educate our countrymen on this important issue. Thanks a lot. It means a lot.
Thank you.
Thank you. Thank you so
Thank you.
much.
Thank you.